Hello, everyone. I have another valuable guest psychiatrist with international work with me. I'm Artin psychiatrist practicing in United States and Canada, based in Washington, D.C. And I'm interested in human rights in psychiatry and existentialism. And we will talk about more about the framework I'm planning to introduce. Now, today I invited one of my dearest mentors that I have had in the past few years. I've worked in a couple of my publications, and I also visited him in his home country, and he hosted me kindly, showing around. Dr. Dainius Pūras from Lithuania, Vilnius, Lithuania, who was a special rapporteur for the rights to health to the United Nations Secretary General. We would like to talk about human rights in mental health and in psychiatry and the details of how different aspects of human rights apply to psychiatry. Dr. Pūras, can I ask you to introduce yourself to our audience?
Okay, hello. First of all, thank you, Artin, for interest in my work. And about myself, I am medical doctor and specialized in child adolescent psychiatry. But when it comes to policies, I am interested in uh, health policy and related fields in general, and of course, mental health policy. So this is how first I was active in my country, in my region, or rather maybe sub-region of Central Eastern Europe, and had this special transition from one system to another, and then yes, from 2014 to 2020, I was special rapporteur on the right to physical and mental health, and I enjoyed this mandate, and I did my best um, to put all these ideas in the reports. And I'm happy that they are still alive and discussed, and I am still quite active internationally, even now already almost 6 years after my rapporteurship was finished, but I'm still quite often invited to different countries to share my experience as a former now special rapporteur. So I'm trying to contribute to this very dynamic discourse on global mental health with special focus on human rights.
Okay, thank you, Dr. Pūras. It's a great pleasure to have you here, and I had the pleasure of working with you in some small projects in the past few years. You talked about starting your work locally in your country, Lithuania, and then going global. And I visited your country. That was a very interesting lesson in history and the transition from an authoritarian regime to non-authoritarian and a democratic system. I want you to talk to us a little bit more about your life and training in Vilnius University, Lithuania, and how growing up and working in Soviet time and then post-Soviet time influenced your life and your work in human rights and psychiatry.
Well, I think that I was somehow, maybe unconsciously, but looking for something in between humanities and exact sciences, so to say, and soft and hard sciences, and this is how I became a medical student. But from second year, maybe medical studies, it was clear for me that I'm interested in that part of medicine which is closer to philosophy. So for me, from the very beginning, medicine was not that much about repairing parts of the bodies. I understand that this is important, but many of my peers, many of my friends in medical studies, they were born as surgeons. They could not imagine medicine in other way. And with all respect to their choice, I had a feeling that there is another equally important part of medicine, and this is how I was coming closer to psychiatry, and then when I finished, I became an assistant professor in my university. But they wanted to, for the first time, they wanted to have child adolescent psychiatry for teaching. So this is how I became child adolescent psychiatrist. And my first patients were my PhD was on children with severe intellectual disability. And I think my roots of interest in human rights is from my contacts with all these families, which I knew personally in my city, Vilnius, about 300 families who had a child with severe intellectual disability and with very brutal, very medicalized and very special approach that the system was hiding these children. So it was part of Cold War to tell to uh, to other part of the world that Soviet Union does not have problems related to mental health. They have heart problems, lung problems, but not mental health problems. So, and the choice was either to abandon these children, that was very strongly recommended by doctors, to parents, or to hide them at home and wait when it is dark and then to go for a walk. So that and I felt that something is very wrong here, and this is how I invented even my own language. You know, I did not know all this UN terminology. I invented my own language, but then slowly somehow I was. There was a suggestion that maybe I could become a member of Committee on the Rights of the Child in the UN. So this was my first encounter with the UN before rapporteurship. So slowly from national level, I moved to international, and as everybody knows, it is easier. It's most difficult to change something in your own country because you, as we say, you cannot be a prophet in your own village. So that it's always easier to cross the border and to
Mhm.
recommend something to other countries. So this is how I enjoyed rapporteurship, but now I am active again back also in my country, and they know me maybe more as human rights activist more than doctor, and but still most complicated question which I receive quite often, both in Lithuania and abroad, and I don't like this question. I am allergic to this question, and I think this question reveals a lot. The question is, so you are a medical doctor? Oh, interesting. So why are you interested in human rights if you are a medical doctor? So the people, very, very high level, important people, politicians and others, they do not see connection between medicine and human rights. So that is a signal. That is a signal, and it's very difficult to find a short answer, to some very important person in
Mm.
maybe 30 seconds to explain. And sometimes I explain in provocative way that if we ignore or sideline human rights, I should recommend to ban such medicine or such psychiatry because it becomes harmful. So that the shortest way to explain. I don't cannot create other answer about this.
So interesting background and life as a story and how you got into human rights. That was actually one of my questions to ask about how you got interested in human rights. One thing you mentioned was the legacy of Soviet influencing you working with the families. Um, we, as you know, our generation, we have heard and we have well seen. I was younger when the Soviet was in power and they collapsed. But we have heard a lot about the Soviet legacy of coercion in terms of mental health management and political abuse of psychiatry by the Soviet Union, uh, which part of it might be the dominance of biomedical model back in Soviet, in my understanding. Part of it might be the lack of respect for dignity and choice in socialist, communist organization and governments. Would you share with us your experience of that? What was the coercion in mental health in Soviet like and political abuse of psychiatry?
Well, it was part of sophisticated, political game. And I know that in so-called West, many people still are very sympathetic about any socialism, including Soviet socialism. And then I recommend that I tell, I'm witness, I was there, I can explain. Maybe the theory was good, but in practice it went wrong because the equality was made through violence. For example, collectivization. Yes, they created these collective farms, kolkhoz, by force. So they destroyed all community spirit. So how can you expect a happy life in that kind of prison, And and the same what they did with healthcare and mental health care was free for all, very, very, it sounds very nice. And then some very reductionist attempt to make everybody healthy or to hide, again, to hide the problems. So, and psychiatry was a special field of medicine which was censored. Because my PhD was in psychiatry, I had to go to Moscow many times to show to professors in Moscow what I'm doing, what kind of research I'm doing. But I would not do this if I my research is in cardiology or nephrology. I could do this in my own language and to defend in my university. But psychiatry was controlled politically because the game of Cold War was that mental health problems are because of capitalism and because capitalism was defeated in Soviet Union, so there are no causes for mental health in society. So everything is schizophrenia then. Everything when person is not just mentally ill, when person disagrees with the government, so he or she is crazy because everybody should be happy, and that became a part of diagnostic system. So the question is that whether these psychiatrists were forced by KGB to diagnose, for example, dissidents. I think no, they were. This was part of psychiatric school. That
Mhm.
if you risk your life, you are crazy. You could why you risk your life? It's not normal. You should be normal. You should adapt to any circumstances, even if it is corruption or something very wrong. You should adapt, and if you don't adapt and you protest, you are crazy. So somebody could say that this is common sense.
Mhm.
So, Soviet psychiatry was well known for this, and even was expelled in the end of Soviet Union. Soviet Psychiatric Association was expelled from World Psychiatric Association. Okay, before it was expelled, they left themselves, yes, because they knew that they would be expelled.
Mhm.
So I was at that time a young psychiatrist, and I was let's say, spying the system, you know. I had good opportunity to spy even in Moscow. And I knew all these famous Moscow psychiatrists. We were in good relations, you know. But I did not like the system, you know. I disclosed the system, and I respect my mentors, but I disagreed from very beginning with their way of thinking. When they diagnose from distance, they see a person and they tell, I am experienced, and I see that this teenager punk is schizophrenic because look at the haircut. He's crazy, he's schizophrenic. And I felt that something is wrong here, you know.
Hmm.
And they were telling you are just when you grow up, you become experienced and you start to diagnose
Yeah.
better. So the
Hmm.
idea was the more often you diagnose schizophrenia, the better psychiatrist you are. So
Hmm.
that was the idea. And of course, the more aggressively you treat the patient, the better doctor you are. You know, again, the more medications, the better dose, the higher dosages, the better you are doctor. So that was the idea which I maybe not hated, but I really did not like. And actually, I was waiting for some miracle to happen, which could be democracy, yes, and of course with my small country meant also independence, but more important for me is democracy. And then I already was prepared for change. How
Hmm.
could I contribute then to change? So I started to work in 81, so I had 10 years to prepare for that, because in
For that to happen.
1991 finally this miracle happened.
Okay, good. Now, speaking of change, Lithuania, your country, and all Baltic countries, they went through a lot of change after collapse of Soviet Union, independence, and then the democracy and uh, inclusion of human rights in their systems. Now, in terms of mental health and psychiatry, can you tell us a little bit more how the institutionalization and community psychiatry was brought to Lithuania and Baltic countries, and what changes happened in the region after collapse of Soviet?
Oh, it was to make maybe long story shorter, because it's now already 36 already years. So beginning was very good because it was a lot of enthusiasm, even among government, among bureaucrats, and everybody. Everybody knew that we have to make things in different way. But then bureaucracy came, which is needed, of course. You have to count money, you have to plan, you have to have some rules for. You cannot just come and open a new facility. You could do this for first 3 years, but then it was ended that you cannot just tell, I know what to do, give me money and I will, you know. And what happened with institutional care? Slowly, the old system was in shock, but then they mobilized and they are still resisting, I should say, which is again understandable because we had a lot of buildings for children and adults to live, yes, for long-term care institutions. So what will you do with this building? So and then EU came because Lithuania became member of European Union in 2004, and EU money came, and then those who were part of the system, for them it was easier to compare with NGOs, for example, to compete for money. So they had many tricks. We learned these tricks during Soviet time, how to take money from Moscow and to do something a little bit different way, yes? It was a lot of skills.
Hmm.
And now people use this with Brussels. They told, okay, we will develop community-based services. They take money and they renovate old institution, they make it better. I mean, physical conditions.
Hmm.
And if you ask, so where is this community? They tell in the yard of this big institution is our community. We sit and drink tea here in this yard. So this is our community, you know. And what can you do, you know?
Yeah.
So I'm not very happy with the developments because after 35 years, we still have, like in Lithuania, which is just now 2.7 million inhabitants, we have 6,000 people, adults in long-term care institutions. And this is
Mm-hmm.
evidence of systemic failure because they still are referred from psychiatric system. Oh, this
Mm-hmm.
person was hospitalized for 15 times. Family is tired, so maybe let's move him to live forever in institution because it's very severe case of incurable disease. Yes, the
Mm-hmm.
brain is very works very wrong, so no chance to live in open society. But everybody understands that it's systemic failure because we did not develop community-based full spectrum of services like supported housing. You know, we mainly have medications for these people, but not psychosocial services. So we could be better. But for children, for example, for children, we still have a very low numbers of children in institutions. So this happened. But with adults, especially with psychosocial disability, we still have, they now live in renovated big institutions, and you cannot close a building which was renovated for with EU money because it's like the holy thing, you know, you cannot, how can you close if it was renovated? So I'm not so very pessimistic, but I'm not happy because it's even not recognized as a failure. And
Mm-hmm.
if NGOs raise questions, so when we will abandon institutional care, there is no such question now. We will not abandon. Nobody forces us to do this. So why should we? So I would formulate that we lost vision. We had a
Mm-hmm.
vision in the beginning, and now what is wrong to have big psychiatric hospital? What is wrong to have big institution? You can go to some other country and find that they have. Why you tell that there is no such places in the world? There are some places. So
Mm-hmm.
this is how compromise is made that don't be. So one of my ideas is if you tell don't be so quick with reforms, it can be forever then. You can
Yeah.
prepare for them forever. So you still must have vision and to monitor. To monitor every year you have to monitor, are you going ahead or you started to stagnate? So this is important to all countries, I think.
Okay. Now, speaking of not being happy with the state of human rights in mental health care in your country and in many other countries around the world, can we talk a little bit more about what exactly we mean when we say human rights-based approach in psychiatry? What are the aspects and elements uh, in human rights approach that we don't do in our business as usual psychiatric practice?
So yes, human rights-based approach is about prioritizing things like dignity, empowerment, autonomy, instead of just looking at symptoms and medications and so it's about values. And if we recognize, like in all medicine, informed consent is crucial, and then for psychiatry, we start to make these exceptions that for psychiatry, we not necessarily informed consent, and then it leads to to violations of human rights. We know this from painful history. So why not to put human rights first? And especially from my experience working on one side of the wall, so to say, and looking to other side, and what I tried to formulate in my reports as special rapporteur, so human rights-based approach was not successfully implemented on both sides because both sides, I mean this Cold War situation again, both sides took human rights selectively and manipulated with human rights with classical situation like Soviets and Americans were fighting, who is worse, in human rights. Can blame both, yes, either economic social rights or civil political rights. But when we come to mental health, in both cases we fail if we sacrifice either economic social rights, what happened with neoliberalism, or Soviet type when you sacrifice freedoms. And you tell that to live in institution is okay because all people in Soviet Union lived in institution. Yes, they lived in closed society. So what is wrong with that? You don't have passport, you cannot travel, but you have some small flat and some food, and that's okay. So to live in institution, if you take these parts of Maslow scale, which are for survival, you get everything. So what is wrong? But then if you tell that I want to be free, yes, I need freedom, then it's so for me, human rights-based approach is both about entitlements and freedoms. Yes, when it is right to health, you need access to health, yes, but don't forget that some interventions can be harmful. So how to prevent this? Then you come to freedoms, and psychiatry is very much about this combining. When you really need services and what to do if the person refuses treatment. So then we have this very difficult situation, and then human rights based approach offers solutions, not maybe for 100% of cases, but then we come to this very difficult situation. What will you do how you will apply human rights-based approach if it is some very special emergency? Yes, then so that this is why this debate is so painful under this impasse situation with convention and so on. So, but I think that human rights-based approach is really very it can be applied practically in sustainable way. And sometimes I compare with AIDS, HIV/AIDS situation, which when it was a very severe epidemics now, 50, 40 years ago. And then the question was, do we have remedy? Yes, we have remedy, human rights-based approach. Stop discriminating key populations. Yes, if we still demonize and discriminate them, they will go underground. They will be afraid even of health services. Yes. And they will go underground, and then epidemics will spread. So politicians decided, even if they don't like human rights, if they don't like drug users or sex workers or men who have sex with men, but they had to apply these principles to stop epidemics. So mental health conditions are not infectious, but human rights-based approach again is crucial as we see now, if we want to manage mental health conditions effectively. So I think it's not theoretical. It can be very practical, but of course there are many problems with implementing it.
Okay, so what I hear is human rights approach has one aspect which is more about policy and health systems, and it's more focusing on social determinants of health, inequalities, discrimination in terms of the policy making and healthcare management. But then, as a clinician, when you put the hat of clinician and go to hospital or go to emergency to take care of patients, how can you balance the safety of the patients with the rights and recovery model in human rights approach?
Yes, so these are most complicated questions and situations. I think the problem is that most clinicians, most doctors, they put immediately put safety as a priority. Also,
Hmm.
because this is question of liability, yes, they tell
Hmm.
what will, if I am too liberal and something will happen, so I will be fired or something like that. And this is why this idea of autonomy and empowerment and non-coercive services is not popular. But the supporters of human rights-based approach, they never told that let's do nothing with the patient. They just suggest alternatives, but these alternatives are
Hmm.
very innovative, very creative, and bureaucratic systems are allergic to such innovations. And this is why still psychiatric services are dominated by classical mainstream psychiatry, which allows coercion, and when you allow coercion, it is overused then, misused and overused, because it's always easier to jump to coercion and not to have a risk and uh, take time and create some alternative. So, but I understand my colleagues, psychiatrists, when we had these numerous discussions. Not always they are fruitful, but they are needed. But I understand the skepsis. I try to understand the skepsis, but I think it's part of misunderstanding here because the understanding of many doctors about human rights is I should say quite primitive. That you should
Hmm.
do nothing. No, it's not about to do nothing. It's about respect. Respect. For example, I was still taught to lie to patients. Yes, I was taught that you have to lie to patient who has cancer, to have that you will live 100 years. Yes. Now it
We
changed.
don't do
Yes,
that. Yeah.
it changed. Some things are changing. Yeah, and I think that the same will happen with mental health care. But in many countries, when I was traveling, of course, I met most of doctors were quite skeptical about these new approaches. Maybe some 10%, not more than 10% of psychiatrists are on the side of this new approach, and many other professionals. Yes, but when we come to
Hmm.
psychiatrists, but I think that they are hostages of this idea of liability, for example. So why then I have this counter answer? They'll say, who decided that psychiatrists are responsible for social control of society? They are not. So maybe we ourselves decided we wanted to be far powerful, and we send a message to politicians that do everything as we told, and then we will manage homicides and suicides. But you cannot solve this problem with just prioritizing psychiatric services. So let's say this openly. Let's share
Hmm.
responsibility with others. So maybe we want to keep a monopoly of power. This
Hmm.
is not healthy. It's not healthy to
Yeah.
pretend that we are gods and know everything. So then we go deeper to this discussion, but I think it is needed. It's painful, but it is needed. I
Hmm.
think that the future of psychiatry is less power and more effective horizontal collaboration with others, and not to tell that we are the only who know what is happening when it is schizophrenia. We don't know.
Hmm. That's interesting. You mentioned a few points that I want to recap. That not knowing what's happening reminds me of Martin Buber and his dialogical encounter with the patient, the I-thou relationship. That the encounter with the patient is usually that the doctor says, I know the answer, you come to get the answer. But Martin Buber says the encounter should be that we are two fellow journey travelers, and we I'm here to listen, and we find the answer together. So, and that resonates more with psychiatry, in my opinion. And I think that's what also you mentioned.
Mm.
Uh, two other things you mentioned, I want to say. One is the liability, and I think the liability comes from mental health acts that makes psychiatrists liable and responsible for certain things, for suicide and homicide. So I want you to comment on that, Mental Health Act reforms. How do you feel about that? How do you think it should happen? And the second thing, alternatives of treatment. In my experience, use of family members, family support, and community services works very well as an alternative. I want you also to mention what other alternatives do you see, and also talk about this too.
Yes, with the mental health legislation, there is an obvious tendency, even also already recommended by World Health Organization, which dropped this requirement to have mental health law, because they realized that each mental health law in each country sounds nice, but has one article which is discriminatory. So, and then we don't need such mental health laws because they discriminate. They allow to discriminate. Instead, one of ideas is to integrate psychiatry in general health law, because we know when then it is some accident and bleeding, we don't ask for informed consent, yes, or when it is some intensive care. Yes, so when then it's compulsory, then it's coercion, yes.
Mhm,
The person cannot run away, you know.
mhm, mhm,
And so maybe some cases can be in psychiatry, especially when it is connected, when it's something organic, something like intoxication and so on. So it's medical case, and then we apply medical legislation. But a lot of cases in psychiatry have nothing to do with biomedical, you know, with critical, yes, with the, I raised this issue in my last report. Made one more provocation. I questioned the idea of list of essential medicines. Yes, and that was very painfully accepted by World Health Organization, because it's a holy thing, you know, list of essential medicine, which is about life-saving medications. And there is a part in this list, it is psychotropic medication. So this was the idea of psychiatrists to tell that psychotropic medications are life-saving. And I don't agree. We
mhm,
simply don't agree, you know, so
mhm,
they should not be in that list. But of course, we can discuss. So with I have a dream that mental health laws or health laws have a chapter that alternatives are needed. I mean,
mhm,
alternatives should be in the legislation. Otherwise, they have no chance to compete mainstream. And when you asked about alternatives, there are many. This is part of these innovations. Global South maybe even is better than Global North with these alternatives. It not necessarily needs a lot of money. It may need, but not. And I like them very much, but sometimes they are losing. Sometimes they are losing to mainstream, like it happened in some Nordic countries. They have some alternatives and they are closed because there's harsh competition. And alternatives, like for example, medication-free units. So people want to be hospitalized, but they are fed up with psychotropic medications. They tell we
Mm-hmm.
need other type of therapy, okay? So go to that unit. Peer support, of course, is very, very good idea, but then open dialogue. But then there are many, many interesting questions. Should we do these alternatives separately or should we integrate them with mainstream? And both have risks, so to say. I should like more to have to protect them from mainstream because
Mm-hmm.
when we integrate, it's somehow diluted. And
Yeah.
then you come to classical psychiatry, and they tell we have a little bit of open dialogue here.
Mm-hmm. Mm-hmm.
This is not how it should be. But these alternatives are, I think, future of psychiatry, but all they signal about the need to move to more democracy. Because
Mm-hmm.
there you move from vertical, relationships between stakeholder between groups to horizontal, and that is for me the same like in society. Either you have
Mm-hmm.
democracy or you have some authoritarian or more totalitarian system. So
Mm-hmm.
so that is happening in the world, but in very chaotic way. These alternatives they survive, but they are not so much liked by let's say governments. Governments will
Mm-hmm.
also ask in crucial situation. They will ask classical psychiatrists how to spend money, how to and this is why this change is not happening so very very quickly, or sometimes you even know if it is happening, if this development is happening should be monitored. So somebody should monitor and see. So this may be such comments.
Now, is Dr. Pūras, speaking of your experience in uh, international work and United Nations, you were, to my knowledge, the first medical doctor who held the position of a special rapporteur to the right to health, and your successor is also a medical doctor. Can you tell us a little bit more what you did during the work you had? What did you enable? What were the challenges you faced? How was it engaging the governments? The whole work of a special rapporteur, the challenges and the stories you have.
Well, so main working methods are that you report. Of course, you report twice per year, once in Geneva, once in you prepare a report, and you have interactive dialogue in Geneva and in New York. But then you have contributions, official contributions, about twice per year. So government will invite you. You go and you meet government people, but you also go with people with civil society confidentially. Then when you have report on that country, but then you have invisible work like you engage with governments, and it's invisible because when you see that something is wrong, you write a letter which is confidential. So you sort of allow to that member state to improve. And then you see what will happen if they reply and they react. But you always have a right what is special, for why these mandate holders are special, we always have a right for naming and shaming.
Mhm.
So nobody can tell to us, shut up. This is because we're independent. We even don't receive salary. I mean, if we receive salary, if we are hired, then we will be fired very quickly because
Mhm.
we are not good boys, or girls. We criticize governments, and governments are sensitive, so they will tell, fire him, and this happens. Also happened with me, and then UN tells it's impossible because we never hired him. We not job contract, so
Yeah.
independent, just mandate holder, but independent.
Mhm.
It's a
Mhm.
very, very innovative mechanism created in the best when UN had best time with human rights, and so that part is also very interesting. And we work with other special rapporteurs. We have joint statements, and then many informal, because I was traveling per year maybe 4 times officially. When it's covered, travels are covered to report on contribution, but then I was traveling many times to some conference, to some informal meeting. Then if somebody covers your travel, then you go, and I was traveling up to 25 times per year, and I like this. So, and then you report, and then you see, of course, the recommendations are not binding. It's up to people to take them and to do what they wish. My method, maybe not very scientific, was just to provoke, to
Mhm.
meaningfully
Mhm.
provoke, because if you may tell things and the opponents will ignore. But if you're a special rapporteur, plus you're a medical doctor, and as a medical doctor, you report that something wrong is happening in the name of medicine of psychiatry, violation, human rights of people are violated, then there is no way to ignore. Then somebody will react, and this
Mhm.
is how you contribute to this discourse, which is very important. So I was happy that I managed to provoke my opponents
Mhm.
for responses, and these responses, I did everything possible that these responses are public, so people can read what was, for example, position of World Psychiatric Association then
Mhm.
in 2017 and what it is now. And I'm happy that they are improving. They were not happy with people who are writing about coercion in psychiatry. Now they recommend to substantially reduce coercion in psychiatry.
Mhm.
So I'm very happy that they're doing this. So somebody has to provoke and to facilitate this discourse. But very interesting question when you mentioned that I was first medical doctor. When I was doing some presenting some reports for example, in Geneva, in Human Rights Council, which is not always friendly on human rights. It's
Mhm.
polarized. On mental health was okay, but if I did report on, for example, sexual reproductive rights of adolescents, so you can imagine then polarization in the world, and which country
Mhm.
will tell good boy and which country will tell what are you talking here, and I was always surprised why, with me, never happened very brutal attacks. Because some special rapporteurs, special rapporteurs, women, for example, they suffered sometimes brutal attacks from some member states. And I
Mhm.
was thinking, I was telling quite provocative things. Why I never received some very angry? And one diplomat told me, uh, he told me, why don't you understand, Dr. Pūras, you're a doctor. Diplomats know that you're a doctor. So that was interesting to hear, that
Here. Yeah.
diplomats are human beings. They know with doctors, it's better not to be in conflict, you know.
Hmm.
So was a joke or not joke, but I think it was not only joke.
Hmm. Sounds like a challenging position you had. And speaking of attacks, I remember I read a report that you were for a while excommunicated by psychiatric associations, the national and international psychiatric associations, on one of your reports criticizing coercion in psychiatry. And that was interesting. And one of the things I want to tell our audience to go and look, and if you want to talk a little bit about it, is your final General Assembly report in 2020. You made some recommendations for uh, human rights improvement in mental health care and physical health care. Now, but some of our audience might be trainees and early career psychiatrist residents. Uh, do you want to give some of your messages in your reports, and especially, as I said, the final General Assembly report to them? What are the core competencies of right-based approach, rights-oriented practice that they need to learn during their training in psychiatry and mental health?
Mm, I think I somehow now I think that I would like to more to connect this with general medical education in general, because psychiatrists are medical doctors, and I think that with human rights we have some problem in general when we in the world when we have medical educations. Medical education, it is not that much about human rights. And what I mentioned already, that the tendency is to train medical doctors more in the spirit of emergencies, yes, life-saving situations. So then, uh, and then, of course, you have to be aggressive. You have to act.
Hmm.
Yes, you cannot be engaged in philosophical discussions and so on. But it does not apply all the time. And in mental health and psychiatry, we have many situations which are a lot about more philosophers told more than doctors about this, like
Hmm.
existential situations and so on. And for me, I liked the position of WHO, but then it was lost. I found in some papers, maybe 30 years ago, about five-star doctor, five-star clinician, that we have to train future doctors like that would be five-star and not one-star. One-star is clinician, good
Hmm.
clinician. It's one star, but then you need four more stars. It's communicator. You have to have good skills to communicate with a patient, and you need skills here, not only. Then you have to be community leader. Then you have to have skills for manager, and ethical and economical decision making. You have you have no right to tell that I'm doctor and don't need to know about economics
Hmm.
or ethics. So then you are five-star, and so but this is equally important to psychiatrists and non-psychiatrists. So of course psychiatrists have some need some additional skills, but I should like that the new generation is not that paternalistic, you know, that because my mentors were good people, but this paternalism was so strong, you know, that we love these poor patients so much, and we will do everything on their behalf. They are hopeless, they don't understand, and we will explain if they have a right to have family and children. You know, of course, they don't right because they are so severely ill. This I heard from my teachers, and I was thinking, what are you talking here? You know, so. Yes, and so I think that this change which happened in the rest of medicine from paternalism to the doctor and patient are partners, yes, should come to psychiatry, and if a patient tells doctor, I don't like these medications, maybe we can talk about some other therapy. I think it's normal conversation. I was taught that if patient tells to doctor that these medications are bad, so you have to increase dosage because he became
Hmm.
more psychotic. He
Hmm.
started to explain to doctor as if he is doctor.
Hmm.
So that was my training. So can you imagine how much I I don't like this paternalistic approach that we
Hmm.
and even I was telling sometimes this nasty joke about what is the difference between doctor and God. Maybe it's not funny, maybe it's a little bit offensive, but I think it's reflect. This the only difference between doctor and God is that God knows that he's not a doctor. So that is maybe sarcastic. But
Yeah.
I met many doctors who really think that they are God, or they think that it's better to pretend God
Hmm.
because then placebo effect will be high. Yes, I agree. But how long we can pretend gods? If
Rely
we
on.
pretend gods, we become very vulnerable
Mhm.
ourselves. We have no um, uh, we cannot make any mistake. Yes,
Mhm.
we have no right to mistake, and then this makes our profession very vulnerable if we tell that we
Mhm.
always are right. And I had possibility because of my rapporteurship to meet with famous psychiatrists, those who write textbooks and so on. And during private conversation, I was asking them, so do we psychiatrists really know more than others about what is happening in the
Mhm.
brain when all these conditions? I tell, of course, we don't know. Don't ask nasty questions. We thought that we
Mhm.
know about these chemical imbalances, but now we understand that we don't know. We have to think
Mhm.
again. Okay, so let's tell this. Oh, no, 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 no. We have to pretend that we know. And I think it's not
Yeah.
healthy. It's not constructive to pretend something. So,
Very insightful and thought-provoking ideas, Dr. Pūras. Now, our last few minutes, I want to talk about something that I have been working on in the past 4 years. I worked a little bit in human rights and then a little bit in existentialism and existential psychotherapy. So I provided you with a draft of my article and the book proposal I'm working on, and that's introducing a framework called right-based existential psychiatry, focusing on I explain a little bit for some of our audience which are not familiar with the project, which is focusing on the common areas between human rights based approach in psychiatry and existentialism philosophy, existential psychotherapy. And in order to achieve that, I introduced a therapeutic model, not necessarily just psychotherapy, which is, I call it deep therapy, DEEP, it's dynamic eclectic existential psychopharmacotherapy, which consists acceptance, the behavioral change, cognitive restructuring, dynamic analysis rooted in psychoanalysis and psychodynamic therapy, and then existential exploration, the fact that we focus on the relationship with the patient and the existential meanings of mental health, and focused pharmacotherapy as believing as a medical doctor that medicine works when we focus on just the right dose and guidelines, and eventually grounding techniques for dealing with situations. So this modules of A, B, C, D, E, F, G as deep therapy. Now, you read a little bit about this novel idea about approaching mental health in a right-based existential. Can you tell me a little bit what you think, tell me and our audience, what you think about this novel model? How do you think it can fit in human rights model of psychiatry, or if you have any ideas about other models that can help bringing human rights into mental health care?
Oh, yes, I read, and I have to say that I liked. This is very not maybe innovative, but this is a very bold attempt to integrate different approaches and what is needed. So congratulations, even if it is just beginning and draft, yes, but you should go on. And I just want to say, in connection with this, because when I started to go abroad finally, because for many years I could not go. Yes, I lived in closed country, but when I went to London and I wanted to meet now late Sir Michael Rutter. He was guru of child adolescent psychiatry. He was most quoted and so on. I wanted to meet him, and he agreed to talk with me. And I was asking him, what can you recommend? Because unfortunately, I received anti-training. I received not real training. So how can I train now new generation? And he told, no, we are, with me was something like that.
Mm-hmm.
Because with him was that in 50s he finished medical studies and he started to work in pediatric unit department of university, and he was told to start to teach new discipline, child adolescent psychiatry. And he told, I don't know. Nobody knows, they told. You just read some book and start to teach child adolescent psychiatry. This is how he became child adolescent psychiatrist. And, and then he told me, such people like us, because we did not receive real training, yes, were needed because we are not biased by any religion. He told in this, yes, religion, because there are many religions in psychiatry, and people become loyal to one religion, and then they are biased because they are not tolerant to others, and then there are these wars between psychoanalysts and I don't know biological psychiatrists or behaviorists and so on and so on and so on, many religions. And then he told that it's okay, people have to specialize. We should
Mm-hmm.
respect the colleagues, but they are lost very often. They are, because of this bias, they are lost. As in my country, they will tell they are lost between three trees. You can be lost with three trees, yes, and somebody has to see the forest. So I
Mm-hmm.
liked this. He did some supportive therapy to me, and I came
Mm-hmm.
back home, and until now I am looking at the forest, and I
Mm-hmm.
see how some good doctors, good psychiatrists are lost, and they cannot see forest, and they specialize too much, and they are biased, and then they are, so this idea to integrate in your model, five different approaches to integrate uh, is very good. Just it would be interesting to see how it works. So how then
Mm-hmm.
how to avoid or prevent these religions. This is what
Yeah.
how
Yeah.
to
Well,
make
mm-hmm.
psychodynamic approach and a more simplified, therapies to make a mix, yes, so which is
Mm-hmm. Mm-hmm.
or to mix with medications, which I liked when you write that medications may be needed, but not as main element, yes. But
Mm-hmm.
my last travel was to Madrid. I was invited to Madrid by Spanish colleagues to conference, and they were looking for alternatives, and was very good visitor. Another presentation was from Switzerland about some, I forgot now, some alternative, famous alternative. Now I forgot this name, but
Mhm.
in which in United States it failed because they were
Mhm.
very anti against medications. Yes, they told
Mhm.
Soteri. Oh, Soteri.
Mhm.
Yeah. So, and in Switzerland it works because they are not against medications. They tell,
Mhm.
okay, sometimes medication, we give medication sometimes, but of course
Mhm.
they are not the main element in therapy. So
Mhm.
that I
Mhm.
think is clever approach. So my just I am happy that you developed already quite much in this model, but it needs further development, and I wish you a lot of success. I liked very much
Yeah,
this
thank you.
attempt.
Thank you so much for the feedback. Yeah, actually, I liked your analogy of looking at the forest because, in my
Mhm.
opinion, my deep therapy model is the integration of these seven different modules, with each of them looks like a religion or a school of uh, psychotherapy or biological approach to psychiatry. And I thought if we can find a middle ground, putting all of them together, it can
Mhm.
fit uh, for a lot of our patients. But however, I totally believe that there's no one size fit all, and each person's condition should be approached individually based on the situation and symptoms. Thank you so much, Dr. Pūras, for your time. Do you have any take-home message or final word for our audience and for myself?
No, I think that such conversations and such, now we talked just two of us, but we need some more opportunities for these discussions about past and present and future of our field, mental health. I always remind, especially to young people, not to forget past, because the past is so illustrative and unfortunately so painful, and all these uh, sad stories, sometimes horrible stories from history of psychiatry, they were made with good intentions. They always were good intentions. That was not the bad people who were doing lobotomy or something. Creating some miracle, how to
Mm-hmm,
repair brain or something. Just we need to learn from those lessons because that this was all about ignoring human rights
mm-hmm,
all the time. It was ignoring human rights. Just we will fix some disorder like in surgery, and that is another type of medicine. It's also medicine, but very different. So we should, and somehow people tend to forget the past, and then they repeat not exactly the same mistake, but very similar. So we should, if we want to predict better the future, it's much of it's in the past, because the development is like spiral, it's
yeah.
sometimes very similar things happen.
Okay, thank you, Dr. Pūras, for the time. And I get a rain check on, maybe having you another time, continuing the conversation, for other topic or expanding the same. And thank you everyone
Okay,
for listening to us.
thank you.